Hello, my name is Mark Schroeder. I'm an Associate Professor of Medicine at Washington University in St. Louis. I will be talking about JAK inhibition in steroid refractory chronic graft-versus-host disease, highlighting two studies, REACH-3 and GRAVITAS-309. Chronic graft-versus-host disease affects 30 to 70% of allogeneic stem cell transplant survivors. Overall survival in high-risk disease is around 40 to 50% at 5 years. Chronic graft-versus-host disease rarely occurs prior to day 80, and most cases occur within 1 year of allotransplant. Chronic graft-versus-host disease is associated with less risk of disease relapse, but also with immunodeficiency and autoimmunity. The pathogenesis is poorly understood, and the disease presents in a pleiotropic manner with multiple organ systems potentially being involved. The standard first-line therapy for chronic graft-versus-host disease has remained corticosteroids. However, 40 to 50% of patients may be steroid refractory, and those that develop moderate to severe chronic graft-versus-host disease have a higher chance of becoming corticosteroid refractory. Steroid refractory chronic graft-versus-host disease has a high morbidity and long-term mortality with reduced quality of life. There are no standard second-line therapies for chronic graft-versus-host disease. Ibrutinib is the only FDA-approved therapy for steroid refractory chronic GVHD. Many drugs have been studied retrospectively and prospectively with potentially high response rates of 60 to 70% in this disease, but the treatment choice for chronic GVHD is often dependent on the provider, the administration of treatments, the need for monitoring, and the risk for toxicity. The JAK1, JAK2 inhibitor Ruxolitinib has been retrospectively studied for chronic graft-versus-host disease. In these retrospective studies summarized in the table, Ruxolitinib has shown responses in oral, cutaneous, hepatic, GI, and musculoskeletal presentations of chronic graft-versus-host disease. These initial studies have suggested partial responses for patients who have lung or sclerodermatous skin findings or severe ocular disease, but complete responses are less common in these organs. Corey et al. Reported that responses to ruxolitinib can occur early and can be sustained, with up to 70% of patients in this series being able to discontinue steroids or go to physiologic doses. Two prospective studies of JAK inhibition in chronic graft-versus-host disease are ongoing. They are REACH-3 and GRAVITAS-309. No standard second-line therapy exists for chronic graft-versus-host disease, and ibrutinib is the only FDA-approved therapy. The primary objective of REACH-3 is to compare the efficacy of ruxolitinib to best available therapy. Efficacy is measured in this study by overall response rate at 6 months. 324 patients will be enrolled to allow a 90% power to detect a difference in overall response rate between best available therapy and ruxolitinib. Failure-free survival and symptom score are key secondary endpoints for this study. The study design for REACH-3 is shown. This prospective phase 3 study will randomize 324 patients with steroid refractory chronic graft-versus-host disease at a 1-to-1 ratio, stratified by moderate or severe disease, to either receive ruxolitinib 10 milligrams twice daily and steroids with or without calcineurin inhibitor, or best available therapy plus steroids with or without calcineurin inhibitor. Best available therapy options included extracorporeal photopheresis, methotrexate, Cellcept, mTOR inhibitors, TNF-alpha blockade, rituximab, pentostatin, imatinib or ibrutinib. Patients would continue on treatment with the primary outcome measured at 6 months of overall response rate. Those patients on the best available therapy arm were allowed to cross over to ruxolitinib treatment if they do not show response at 6 months. REACH-3 is a phase 3 randomized open-label multi-center study. It will enroll patients greater than or equal to 12 Patients have to have evidence of engraftment and adequate organ function. They cannot have received prior JAK inhibitor therapy. Patients randomized to the best available therapy arm may be allowed to cross over to ruxolitinib treatment. Follow-up on this study will continue for 3 years. Steroid refractory chronic graft-versus-host disease is defined as in those patients with chronic GVHD duration of less than 12 months, lacking a response or disease progression after administration of 1 milligram per kilogram prednisone for at least 1 week, or disease persistence without improvement despite continued treatment with prednisone at greater than 0.5 milligrams per kilogram per day for at least 4 weeks, or increase in prednisolone dose to greater than 0.25 milligrams per kilogram and inability to taper the dose. Patients were excluded in this study if they transitioned from active acute GVHD to chronic graft-versus-host disease and were unable to taper from corticosteroids and calcineurin inhibitor. The first patient was enrolled to REACH 3 in June of 2017, and enrollment is ongoing. An expected completion date is July 2019. GRAVITAS-309 evaluates the JAK1 inhibitor itacitinib for initial treatment of chronic graft-versus-host disease. No therapy added to corticosteroids has been shown to improve response in treatment-naive chronic GVHD. This is a randomized placebo-controlled trial after an initial run-in of 20 patients to determine the optimal dose of itacitinib. Part 1 will evaluate for dose-limiting toxicities of 2 doses of itacitinib, and Part 2 will evaluate the overall response rate at 6 months. Patients must have moderate to severe chronic graft-versus-host disease per NIH consensus criteria. They must have undergone allogeneic stem cell transplant and have engraftment and be in remission. This is the study schema for GRAVITAS-309. Part 1 will enroll adult patients with moderate to severe chronic graft-versus-host disease, newly diagnosed, having received less than 3 days of corticosteroids, and randomize these patients to receive itacitinib at 200 milligrams daily with corticosteroids or itacitinib 300 milligrams daily with corticosteroids. Day 28 safety is being monitored, and based on the results of Part 1, the recommended Phase 2 dose of itacitinib will be carried forward in Part 2, which will enroll the same patients with newly diagnosed chronic graft-versus-host disease and randomized to either itacitinib or placebo plus corticosteroid, with the primary outcome of response at 6 months. An interim analysis for futility is planned in this study after 70 subjects complete their 180-day visit. The study is powered to detect a difference of 20% in 6-month overall response rate between the control group and an experimental group. The study started in January of 2019, and the primary completion date is estimated in August of 2023. In conclusion, REACH 3 is evaluating ruxolitinib for steroid-refractory chronic graft-versus-host disease versus best available therapy, and if successful, may result in FDA approval for this indication. GRAVITAS-309 is evaluating the JAK1 selective inhibitor itacitinib in newly diagnosed chronic GVHD with the hopes of being the first drug combined with corticosteroids showing efficacy in treatment-naive disease. This ends this episode, and I would like to thank you for your attention.